Again, let me welcome everyone to the second installment of the Public Health Systems and Services Research in Progress webinar. Thanks everybody for joining us today. We've got another, I think, very interesting session teed up for today. A chance to take an early glimpse into some cutting edge research on public health delivery. With another one of our mentored research scientists scholar award recipients, and we're eager to hear from the great work that's happening through our next presenter. I'm Glenn Mays. I'm the director of the National Coordinating Center for Public Health Services and Systems Research, a co-conspirator with my colleague, Dr. Doug Sketchfield, who hosted last week's Research in Progress session. And pleased to introduce for you the speaker and reactor for today's session, Dr. Thaddeus Miller. Dr. Miller is Associate Professor and Interim Chair now of the Department of Health Management and Policy at the University of North Texas Health Sciences Center. He is, in his academic role, he directs the Health Management and Policy concentration for the M.P.H. and M.H.A. degree programs there at the University of North Texas, and also has an active research portfolio in public health services delivery. Specifically, much of his work concentrates in the area of tuberculosis control and looking at a variety of issues around delivery of prevention and control strategies for tuberculosis. And I'm very pleased to see and to learn, become aware of his work over the last couple of years, particularly because of his long history of collaborative research with real-world public health decision makers, on the ground decision makers and practitioners who were involved in the very important issue of tuberculosis prevention and control. A lot of his work is focused on understanding the value of effective tuberculosis control strategies in building up that evidence base about the health impact and the economic impact of TB control strategies, and toward making progress toward the goal of ultimately eliminating tuberculosis within domestic settings here in the U.S. A lot of his work recently has been done in partnership with his local public health delivery system there in Texas, the Tarrant County Public Health. In that part of that work, Dr. Miller serves as PI of one of CDC's tuberculosis epidemiologic study consortium sites, which is a kind of a national practice-based research network of sites around the country that conduct applied research on tuberculosis control. He also does work internationally, and he's done work with the Ministry of Health in several former Soviet states. He's done work in India. He's done work in Saudi Arabia, and a number of other settings. Dr. Miller, he was a recipient of our first cohort of mentored research scientist awards back in December 2012. So we are today taking a peek over his shoulder into research that has been underway for about a year now. And again, the focus of the research he's conducting under the Mentored Scientist Award, again, focuses on using some of the tools of economic evaluation to understand the value of domestic TB control efforts, particularly those implemented in public sector public health settings. And as with all the Mentored Research Scientist Awards, Dr. Miller is partnered with an esteemed senior researcher who provides scientific advice and mentorship during the course of this two-year award cycle. the senior mentor for this project and for this award is Dr. Jose Pagan, who's was formerly a colleague of Dr. Miller's there at the University of North Texas Health Sciences Center, and now has moved to become director for the Center for Health Innovation at the New York Academy of Medicine, another very important public health scientific body that works closely with us in the public health services systems research sphere. He moved there, I think, about a year ago. Prior to that, again, he was also based at University of North Texas Health Science Center and was the professor and chair of the Department of Health Management and Policy there. Dr. Pagan is I think, well known for his work in economic evaluation studies applied to a variety of health and public health topics. He's a former RWJ Health and Society Scholar, and has, again, done some very important work both in the healthcare as well as the public health space. So I think we'll also be hearing a bit from him as well, commenting on this research if he's able to join us today. So let me check now. Let me see if Dr. Miller is with us. Now I see Jose. Dr. Miller, have you joined us now? We may still be waiting to hear.
I think, Lynn, this is Anna. I think that there might be some technical difficulties that we're trying to work through with Dr. Miller.
Okay.
I believe Ann Kelly and her team are trying to get him on the line right now. Do you think we might fill this time for just a moment, since we have such a terrific audience, talking a little bit about the importance of understanding public health costs right now, and some of the efforts that are underway there?
Well, I think that's a very good idea, Anna. Thank you for that suggestion. So yeah, while we're waiting for Dr. Miller to get online, I can certainly tell you a little bit, describe to you a little bit more about the larger portfolio of work focusing on cost and economic evaluation work applied to public health delivery settings. This is obviously, has been an important area for the PHSSR enterprise for a long time now. It's one of the four major pillars of the PHSSR research agenda, the national research agenda that was released last year from RWJ and CDC, is dedicated to studies of cost effectiveness and efficiency in public health delivery, and certainly this project of Dr. Miller's fits right into that stream. If we look at the larger body of research in this field, there's been a lot of work historically that's been done looking at public health expenditures, understanding variation in public health expenditures, and looking, as well as a number of colleagues on this call and otherwise. There's been much less research historically to look at true costs of delivering public health services and cost of undertaking public health activities, and really understanding how much of that the spending variation that we see across communities or across states is a result of underlying cost variation. And that's obviously very important for teasing out, for being able to comment on issues like value and efficiency and cost effectiveness in public health delivery. So one of the other initiatives that we have launched with the Foundation support over the last 6 months or so has been a series of new studies focused specifically on cost estimation. First, on refining some of our methodologies for generating estimates of the cost of public health delivery, and then secondly, using those methodologies to study variation in cost of delivery to identify public health system characteristics that generate variation in cost across settings, and then understanding some of the consequences of cost variation in terms of issues like efficiency and cost effectiveness. So we've launched officially back in August of 2013, so about 6 months ago. We launched a series of new 11 new research projects through our public health PBRNs, all focused on those issues of using good methodologies to estimate cost of public health delivery, and then to study variation in cost of delivering high-value public health services and programs across different types of public health settings to tease out some of those determinants and consequences of variation. So that's one of the additional components in our larger research portfolio around economic evaluation work in public health delivery. Those studies collectively, we call them the DAX studies, for public health delivery and cost studies. Again, there are 11 of them that started up about 6 months ago. Half of them are short-term 12-month studies that focus primarily on cost estimation, and another 6 of those studies are somewhat larger, somewhat longer term. They're 18-month studies that go beyond simple cost estimation to then apply those estimates to studying determinants and consequences of variation in cost of public health delivery. So those studies are also up and running. We will be featuring some of the work in later editions of this seminar, the Research in Progress seminar. Will be featuring some updates from those studies that are underway now. And again, those are planned to be completed in August or in December of 2014, depending on the time cycle. So those are that's another more recent addition to our portfolio in the kind of economic evaluation and cost in cost arena. A couple other things I can share with you that are also in that same portfolio. There's work that's underway. It's been underway now for several months. That has been undertaken in response to one of the recommendations from the 2012 Institute of Medicine report that focused on public health financing that many of you may be aware of. That report was issued back in the fall of 2012. That took a careful look at issues of financing and funding in the public health system, identified problems and gaps and uncertainties, and then made a series of recommendations for improving public health with a focus on financing and funding. If you haven't read that report, by the way, strongly recommended reading. You can access that report for free from the IOM website. But one of the 10 recommendations from that report was for the federal government to convene a series of expert panels to identify, first of all, the components of a minimum package of public health services and programs and activities that are recommended for being available nationally. This kind of minimum package of services that really every community, every citizen should be covered by. And then secondly, to estimate the cost requirements associated with that establishing and implementing that minimum package of public health services in every state and community across the U.S. So in response to that recommendation, starting about mid-2013, the Robert Johnson Foundation, in partnership with CDC and several other national public health organizations, began the process of convening those expert panels. First, an expert panel was convened to define the elements of that minimum package, and it was the first work group to begin work. It's been meeting for not quite a year now, periodically through meetings in Washington, convened by an organization that has expertise in planning and consensus development, called Resolve, based in Washington. That work group, which is kind of the shortcut name for that work group, is the definitions work group, to define what activities, programs, and cross-cutting elements of infrastructure should be included in this minimum package of public health services. That work group is, it's at least the first stage of its work is nearing completion in terms of defining the elements of that package. And then starting back in the fall, starting in September of 2013, our group here at the Coordinating Center was tasked by the Foundation and the other sponsoring national public health organizations to convene a parallel expert panel to make recommendations around a methodology and strategies for estimating the cost requirements associated with that minimum package of public health services. And so, again, we began that work early in the fall, undertaken that work with attempting to be a little bit more rapid cycle in terms of coming up with a consensus-based recommendations around methodology for cost estimation. We're also kind of wrapping up now in a final stages of wrapping up that work associated with again recommending a methodology for cost estimation around this package. And our work, I'd say, at this stage of the consensus development process, our work around cost estimation has focused specifically on the cross-cutting elements of public health infrastructure, which historically had been some of the more kind of difficult elements of public health activity to first define, and then secondly to actually estimate, to generate cost estimates around. So our expert panel work at this stage has focused squarely on identifying a methodology for estimating the costs of implementing this the cross-cutting public health infrastructure, or what's being called public health capabilities that have been defined by the larger definitional work group. And like I said, that our expert panel on the cost estimation panel is our work is entering kind of a wrap-up phase now, as we're making some final adjustments to the recommended methodology, and then that work will be reported out and likely move into a next stage of potentially implementing methodologies to estimate these kind of costs. So those are two, at least from our perspective at the Coordinating Center, two important kind of new elements to the kind of economic evaluation and cost and efficiency research portfolio that is a part of the Public Health Services and Systems Research enterprise. So I am told that our esteemed scholar, Dr. Miller, is in the process of logging on now. He's had a few technical difficulties, but he should be with us here in just a moment. I'd be glad to pause.
Ed Miller.
Oh, fantastic.
I have got nothing but apologies. I got pulled off into a student conference, and anyway, okay. So
no problem. Hey, we can understand that. This is we're the academic session that started up here at UK as well, and that always throws us for a loop in terms of scheduling. So I've just been taking a little bit of liberty to update folks on some of our other economic related studies in the PHSSR portfolio. And so with that, wanting to make sure you've got plenty of time, Thad, let me, I've already done your introduction. Hopefully I did it justice. If you're ready, I can go ahead and turn it over to you to give an update on your work.
So I'm not familiar with the way I move through slides. I'm looking at this on my screen right now. Is this something I have control over, or do you guys move through slides with me?
We can do it either way. You should have control. There should be on the lower left-hand corner of your screen, there should be two arrows, a left pointing and a right pointing. There you go. You got it.
All right. Well, I won't belabor this intro other than to say I was given the opportunity last year to work with the Texas Department of State Health Services, which, you know, we have our state health department, then we've got our oftentimes regional and local departments, but it all trickles down from the top, to work with them on a project that would look at the return on investment for many of their program components. And they said, we'd like to use a case study example, to just show our staff from all over the health department, how to speak in these terms, and then also to dig more deeply into some of the questions that we have that are specific to our programs and our agencies. And these are things that I have done and been doing with tuberculosis on a national and also state level for some time. And what we have found with tuberculosis issues is that we know very much about the disease and the natural history and the course of illness and so forth, but there's this constellation of impact that is created by tuberculosis, health and cost impact, that isn't really well understood. We know how to treat it and the medicines and what to expect clinically, but what to expect in terms of, what will this disease do to my agency if it occurs more, or what is the value or the advantage of sort of stopping it in its tracks using this new technology that I'm being offered versus not doing it. The whole idea of the opportunity cost of tuberculosis as a as a focus of public health authorities' efforts, and what investments are good investments and what investments aren't. So I jumped at the chance, and we have found in tuberculosis, for instance, same as many other things, that you would believe that prevention is the best value. And in some cases that's true with some diseases, and some it's not. In TB, it was thought that prevention is about as expensive as cure. But we've done some work to find that they're really not clinically equivalent, and they're really not economically equivalent either, because there are these things that create costs that are not counted in just a cost of cure versus the medical cost of prevention. So, things where the value is not well understood, they go to the head of the line as far as things that might be cut whenever allocation decisions are being made. And we've also seen with TB issues over time that when political pressure to maintain infrastructure wanes and infrastructure is cut, there is a direct resurgence, a direct impact, and people get sick, the disease begins to spread, people die, much cost is created, and it goes in a cycle, and it's largely due to the fact that the value of these programs are really, they're invisible. So, looking for value and looking to describe value is, something that the health department was highly motivated to do, and I think that's going to be more and more part of our conversation nationally as, as we're trying to express where our priorities ought to be, and we're judging against criteria that oftentimes can't even be seen because, prevention, when it works well, means that nothing happens, right? That's not very satisfying when you're looking for value. So it's kind of a setup, how are we going to tell you how much nothing happened to say that this is valuable? One approach that we've taken is to look for the impacts of a case of tuberculosis, the variable impacts, and be able to sort of quantify those things in a way that is much more tangible than saying, well, a case just didn't happen. But to say, well, not only a case didn't happen, but you didn't spend these dollars on treating people that you thought had tuberculosis but actually had another infection. But it's such a dangerous disease, we presumptively treat people until the tests come back. And the tests take a good deal of time to come back, several weeks sometimes. And so, we can convincingly argue that when we are effective in preventing a case, we not only prevent the medical treatment that would have come along with that case and the morbidity and mortality that came along with the case. But we can prevent this large investment of effort and infrastructure and sometimes very real dollars bleeding away because this case never happened. So we never have to do a contact investigation else. It's somewhat doable to do a one-off look at this sort of thing. You go in and say, well, what are our budgets? But when you're looking at things on a state basis, you don't want to engage an economist or a CPA or a master's student or whoever to come in and study circumstances over and over again. We don't really have good tools to look at these things in a highly interactive way that's specific to our condition of interest, specific to our perspective as a health system and so on. And a lot of the work that we've done over the past several years with CDC and then here locally is to sort of get the pieces of information and the pieces of logic that are necessary to build a modeling tool that can be much more dynamic, much more flexible, and much more broad than you can be with just simply coming in and doing a one-off study. And so with a tool like that, then we can start to look at some of the important questions. Are we doing what we think we're doing with the money that we're sinking into this? Should we do more of it? Should we do less of it? Is it value that we're getting out of it, considering that we could have used the money on something? Is there something that would be disproportionately useful to us to do, but we aren't doing it because we haven't recognized that it's a real driver of effect? And then also, we're talking to non-health people in allocation conversations. We're talking to people whose interest is in maintaining an affordable budget, or in using monies for a project that they do have a more knowledge or background or interest. And so we have to be very effective advocates, and we have to speak in terms that are easily understood and that resonate with our decision makers. And dollars and health do. Saying, well, we're going to prevent TB, people's eyes glaze over and they think about, gosh, so I'm going to be saving folks that are kind of on the fringe in our society. Yeah, that's noble, but they're not going to vote anyway, and nobody's, I don't know. Let's put the money into something that it connects more with the people that I'm obligated to connect with. So having an effective message, using words and measures that resonate with our decision makers is really important. I spoke about this a little bit. Tuberculosis is it's something that, to many appearances, we have achieved what we wanted to. It is not something that we see around us all the time. Many of you, most of you, I suspect, have never had any personal connection to someone with tuberculosis. If you do, it's historic very often. My grandmother, her mother and older sister both died of tuberculosis. It's a family of 4. It was, early in the 20th century. It really meant something to people in the pre-antibiotic era. People, you didn't have to convince them that it was valuable to avoid TB or prevent TB or to eliminate TB. That has that's a message that doesn't resonate very much anymore. It doesn't mean that it's less dangerous. It just means that we've kind of put out the blazing house, but there's still embers glowing. And if you neglect those, they will flare up, and they do. And so it's really incumbent on us as either health system participants policy participants or public health practitioners to point out to people, look, just because you don't see something all the time doesn't mean that it's not waiting there to get you. You got your hands on the throat of this snake. You've squeezed it down, but if you let go, it will come back. And certainly, if you look worldwide, there's no control. It's an awful circumstance. So there's really, I believe, a sort of a critical obligation on our part to point these things out in ways that are effective. So what we did was, in a collaboration with the State Department of Health and our local public health training center here set this up. They had me go down to Austin and first do some training with people on just how do you measure health effects and how do you quantify the investments that it took to produce those, and how can you compare unlike programs in some comparable, how do you get apples to apples comparisons so you can see which one is value relative to another. So they're motivated to get this idea and way of thinking into the health department. So they had me begin some training with them. I did that, and then they had me sit down with the TB people and build together a model that would fit their interests. They had very specific questions. Should we invest in this technology? There are some diagnostic tests that are more expensive, yet more sensitive in some ways than the old standby. They really wanted to know, should we keep doing what we're doing? Should we spend all the money that it's going to take to upgrade this? Is it worth doing? At the same time, we're having, Texas has a legislative session every other year. We set our budgets for 2 years at a time. We were in that cycle at this time. This was last spring, very early spring last year when we began this. And the Commissioner of Health is having to justify to a bunch of non-health people why he needs these dollars, not just for TB, but for many, many things. And he has to justify to his staff how they're going to be used within his department. And within the departments, you want to sort of prioritize your efforts in terms of their utility and their return. And the approach that we took to do this was to build a model that was off the shelf and could be used, very, very well. It doesn't just answer one question. It is something that can be recalibrated and kept up to date and used to answer many kinds of questions, many of which are not relevant to one agency or another, but it has the capacity to do all that. And by off the shelf, I mean we just used Excel. Excel's brittle and kind of tricky to move around and so forth, but it is something that most of us are familiar with. And we did this with some very specific TB logic and data, and then Texas-specific real assumptions that represent what the programs do here and what they don't do. So it's, as a model, all models are theoretical. This one is as realistically theoretical as we could make it. I won't bore you with the details, but we also used off-the-shelf standard approach to to model out costs. One of the big troubles with looking at the value and return of health-related things is there's often an inconsistent approach. An accountant will do things in one way, and a doctor will do things in another, and you end up with these comparisons that are they're meaningless. People make bad decisions because they think that something is is more valuable or less value than it really is. So we built into this, conservative logic so that we would only underestimate any estimates that were produced. That way, always fall back on the results are at least X, Y, and Z. They are likely much greater than this, or at least greater than this, but they're not going to be less than this, which is the strongest arguing position for anybody in an argument. You don't want to say, this is a high estimate, but it's an estimate. So anyway, we built all that in, and I'll show you some examples. The strengths are that, this is something that you can, you can really custom fit to your issue. You can really look at your population. You can look at your strategies to intervene in their health. You can look at, what if I use this test, or what if I use that medicine? What if the vendor begins to drop the price on this, whatever it is, lab, equipment? What if suddenly we can do this for no investment on the behalf of our agency? That's something that we're all looking at now, as Medicaid is poised to pick up the bill for some things that it hasn't in the past, at least for some populations. Now, not in Texas, but that's a whole different conversation. So we can compare, very small program changes, compare all kinds of stuff, whatever, and hold everything else constant. And so we're comparing scenarios, basically. We're not saying, this is a head-to-head comparison of something that is not realistic. It is a comparison of a program in action, but with alternative bits and pieces. On the other hand, a model is a model is a model. It's an estimate. If you ask me for my phone number, you certainly want my phone number, not an estimate of it. There are also many things that we do in healthcare that are done not because they are economic priority. We do things because they are important to do. Sometimes they're an ethical obligation. It doesn't matter if it's not a value buy or not. You still are going to do it. When you're comparing scenarios, you are just comparing scenarios. This is an outcome that you reach given this set of circumstances that, on average may represent quite well the outcome for a state. But of course, an average is made up of many, many, many tiny parts. And in this case, the tiny parts are individuals. And what I say is goodbye means that it's a goodbye for the state on average. For you as an individual, it may be an awful choice for you. You may be allergic to the medicine that is the one that Medicaid will buy based on my recommendation. Well, that's a weakness, that's a limitation, but it is something that then is dealt with in the clinical interaction. And of course, if you put bad information in, or you have bad algorithms, bad results. And finally, maybe the most important limitation, and one of the things that I really urged the health department when I left this tool with them at the end of it, I said, look, you guys, you need to know what you're looking at to make decisions with a thing like this, because if you are going to make recommendations that affect other people's health, you need to make them with your eyes fully open. And, call me and we'll talk about this. And we do. And as I said, this model is set up to underestimate everything. It's not set up deliberately to underestimate, but it's set up so that we look at a very conservative outcome, or the most conservative outcome. I mean, it turns out that with tuberculosis, if you've been sick with TB, even if it's cured, you remain somewhat damaged in terms of your health capacity for the rest of your life. I didn't think that it was productive to try to model out to the end of expected lifespan, so we just capped it at 10 years, very much like CMS's actuary would do, or any government modeling. They anything could happen 20 years from now, 25 years from now. We all may be speaking Chinese or Russian, or living in caves, or have gotten magical technology from space. Who knows? Let's just stick with 10 years. So I put this slide in. It's an embedded link that it turns out won't actually work. So we sent everybody a copy of this Excel spreadsheet. And you can look at it if you like. I'm not going to try to talk about it as though everybody is there, but basically what it is a one Excel workbook with many sheets in there, each of which contain the data, the epidemiology, the natural history of disease, the susceptibility. Of a person to move from a well state to an ill state, their prognosis under treatment and out of treatment, so that at the end of the day, all of these little tiny bits of information sort of work together to show. Lost my screen. To show an outcome. Sorry, I have got a blank screen. Does everybody have a blank screen right now?
I'm looking at your spreadsheet model, so I've got a clear view.
Well, okay, so the PowerPoint presentation, does anybody have that up? And all right, so I don't even have my arrows to move forward. I may have done this, or
I think there may be a fix.
Yeah, there's a share my screen. Let me see.
Let's see if it comes up again.
Okay, yeah, there we
So
go.
we're back to your slides now.
So you guys can, spend time if you like looking at this spreadsheet model. It's, that's another limitation of Excel. It's decimal dust. I don't expect it to be something to be user-friendly, although it'd be nice if it were. But what it is functional and flexible in a way that I found very useful, and the health department did also. And I did include, some comments and notes about the source of things. It's all really for my own reference as we write this up, so that this can kind of get vetted out there in the peer-reviewed literature, so we can say, this really is a valid approach to this, to this problem, and then hopefully get, a little bit more widespread dissemination. Anyway, at the end of the day, what we found was in a comparison of should Texas statewide keep doing what it's doing in terms of its default diagnostic and treatment of people who have a pre-tuberculosis infection. There's a latent stage of TB that imparts some risk of future disease, but not that much. But it's dangerous disease. You don't want to get it if you can keep from it. And we can treat that with antibiotics. We can recognize it with a skin test. We can interdict. And so I looked at what Texas does right now, and I looked at their outcomes, and I looked at the population prevalence that we're testing, and on and on and on. All these sort of finely grained variables. And I found that for starters, to look at, well, what is going to happen as a consequence of 2011's TB incidents in Texas, right? So if these cases had never happened, which is U.S. domestic policy is to eliminate TB. smallpox was eradicated. That means it's only in freezers in Soviet Union and Atlanta. Elimination is a case per million population, so it's different than eradication, but it's still a very, very, it is a tiny background level. So had we not had all or most of these 1,325 cases in 2011, over time, over the 10-year window that I looked at, over $100 million of public sector prospective spending will have been consumed by those folks that were sick back in 2011. More are sick this year. More were sick last year. More were sick. There were people in 2010 and so forth. So you can see that by illustrating the impact of that cohort of sick people in that year, you can begin to shape the conversation about, well, what if we had those guys not sick? What if they just had never happened, had never darkened the door of the health department, on and on. Well, here, that's what would have happened. We would have had $100 million worth of state treasure to use for better education, straighter roads, whatever it might be. And that's not to even get into the health losses that are associated. And in health economics, we try to standardize health outcomes, and one way we do that is with looking at a quality adjusted life year as sort of a basic measure of health that is produced or lost or preserved. And I won't belabor what a quality is, but we often spend an exorbitant amount of money to produce or save a quality equivalent of health when we do things like organ transplantation and so forth. It can be, it can cost hundreds and hundreds of thousands of dollars to, for every quality preserved by putting airbags in both sides of a car, for instance, instead of only the driver's side. But 4,800 qualities basically represents, a year of good, healthy life for 4,800 Texans, or, some number of lifetimes. That would be 50 lifetimes, more than that, of good, healthy life. That's, that's on top of money. So you have two arguments in one. You have, if you don't care about human beings, you still often care about budget and having that available for your pet purposes. On the other side of the coin, many of us don't care about the money it takes to preserve health. We are in it for health and humans, and so you have both arguments, and they're distinct. I didn't attempt to put a dollar value to qualities. That's a losing proposition, unless you're a plaintiff's attorney. They like doing that. The societal costs are likely much higher. In other words, this is the spending from an agency perspective. This is what sort of state budget dollars would see as an impact. Another way to kind of couch the same outcome is that our public spending in 2011 preserved 3.7 qualities for every case that didn't happen, could have, at a reasonable rate. In other words, state investments of $54,000 in TB services would keep one quality from slipping down the drain. Unit of human health that's equivalent to a healthy year of life. But it cost us more to do this than to not do it in terms of just dollars. Now, this is a hard thing to grapple with. We like to think that there is a return on investment, right? They'd asked me to look at for them initially. The idea that we're making an investment and we're going to get back more than we spent. And there's a fallacy because they count the receipts in getting back more than we spent as the dollars that we get back or don't spend. But, the health has value. So we do get back more than we spend. We get back health, but we do it at a cost. And so there's the state right now with their strategy right now, the scenario that I looked at, for every case prevented, it costs, there's a net loss anyway of $1,300. So that's after all the benefits are compared against all the costs, we come out in the red, not in the black. That's not a bad thing. That is all healthcare except with very few exceptions. It costs more to produce health than to not produce health. The cheapest thing you can do in a health system, I suppose, is to let someone die rapidly. But nobody argues that that's a good thing. So this slide just shows the breakout of all this. How many cases were there of what kind, and how much did each one of these events contribute in this sort of weighted look at the total cost to the state? Health loss is the same. Where did those come from? So a table like this just kind of shows, the parts that sum to the conclusion. And of course, that table then will change every time we move things around in that model. This table changes. I made the model, so it just produces this table. And you can just pull it out and paste it into your document. I did look at the return on investment because the state had asked me to do that, and I showed them that under this strategy, given these assumptions, there is a net loss with this strategy. And then I very carefully couched this argument that a net loss is not necessarily a bad thing. It is absolutely the most common outcome for healthcare. But also to say that there are careful program choices that we can make to actually become a health investment that returns more dollars than it spends. The targeting, and so you can play around with this, and you can find the sweet spot or the the program component that gets you to wow, we spend the money and we receive more savings than we spend, and that's always a fantastic thing to be able to carry to your legislature. You can justify doing this because you say it just pays for itself as it goes. There are many things in these scenarios that could. Then I looked at their specific questions, and I found that the standard of care in Texas is the cheapest among the alternatives that we had. And we looked at all the alternatives that are available, and even one that isn't in practice yet but is on the table. And then to satisfy the economists in these conversations, I looked at the cost effectiveness of each of these things, comparison. So to see if we wanted to add this new technology, do we become better at a reasonable cost, like replacing your car, right? If it is reasonably affordable to replace your car with something newer, a little better, a little flashier, you'll do it. But there's a point at which you won't. And here you can see that some of these things, these new technologies, run into the multiple millions of dollars to upgrade the program a little bit. Yes, you get a little better outcome, but it is an outcome that is unaffordably expensive. You do get better health, yet we only have so many dollars to spend, so we really try to spend them wisely. Then you can see there's some things that you can get a better outcome somewhat affordably. I played around with this a little bit to look at how does that change if we begin to more carefully target our screenings and our treatments and so forth, and found that you can really bring down the cost per outcome. So if you look at the next to the last line on this table, the average cost per quality saved, you bring down the cost per quality into the $12,000 range. That's really quite a good buy in the health system. that's considered quite cost effective. Remember, cost effective doesn't mean that it returns money. It just means that it is a good buy. So at the end of it, I reported back to the state health commissioner, David Lakey, and his executive council and the TB people there, and gave them our conclusions, which are that you guys are doing a good thing, and you're doing it at an affordable cost. You could do it better. I mean, there are things within this system that are ripe to squeeze more juice out of, and it would be it would be easy to pick out those things, and we did pick them out, and we did. I gave them a report and said, do this, not that, do this, not that, and here are some returns that you can. And then I quantified that. And I think perhaps one of the really important things that we had as an outcome was a nice, comfortable, open working relationship between me as an academic, the health department as practitioners, folks within TB services all around. That was, I think it opened a lot of eyes on the practice side to the potential value of forming partnerships like this, and it opened my eyes certainly to years ago when I started looking at these. Well, we'll always go from a societal perspective when we do an analysis like this, because that's really inclusive in a way that it needs to be, and I know you guys don't care very much about it, but really it's the right thing to do. In this case, I said, well, we don't, we really aren't going to look at the total societal value here, because I'll be giving you something that is the wrong answer to the question that you have. It doesn't help you. And, many things like that. And mainly, they call me and they say, hey, can you help us with this? Can you help us with that? And, and I help them. And I feel good because it helps direct their their efforts in a way that I think is sensible and efficient, and that satisfies the pragmatic side of me. And they like it because they like to know that they're doing the right. They like to know they're doing what they intend to and expect to. And also, we kind of demystified these these topics using Excel, although I did it because it was available and free and ready to use and all that. Yeah, it was also useful because, I think people were like, we could carry this to our dialysis efforts or, our flu vaccine efforts. Well, okay, so at the end of the day, the very end of the day, action was taken based on this project. It took 4 months, I guess, of going back and forth to Austin, sitting down with the TB team. Every single week I reported back to them in a very collaborative process. I would say, so here's what I've got. What do you guys think? And they would look at it and they'd say, well, have you considered this and have you considered that? And we'd really like to know this. I included in the final model, almost everything that was on their wish list. What I didn't include was the capacity to model out effective comorbidities, which is a shortcoming that I didn't point out in the limitations. But, there is a sort of a leveraging effect of things like cigarette smoking and diabetes on many illnesses. Some of tuberculosis and diabetes or latent TB infection and diabetes is more than the sum of the parts of either thing alone. And they're very interested in looking at the value of, can we intervene in someone's diabetes management and have this, this reward in a whole different disease system, different division. Can we handle diabetes more well, and as a result have less impact from tuberculosis? The answer is yes, but we weren't able to model that in with this. We know that this has to be true, but that there will be some effect. We don't know if it's an effect worth investing in or not, but they would like to do that, and I think that's very forward thinking, and I intend to build in a sort of the comorbid aspect to this. I'll come back to the questions, but I should say I didn't do this alone. I did this with the help and the advice and the input from folks all over the place. Nationally, regionally, locally, and all the work that we've ever done with TB and TB economics really began in our local public health department in Tarrant County, and Lou Brewer and her team have been accessible, and their doors have been open to research of all sorts in their public health department for many, many years. Without that kind of openness, which does nothing but get in their way, on a daily level, our presence is a distraction, and we take up space and everything else. Yet they are their eyes are completely open that if we want to do things better than we're doing them right now, we have to put up with people in our way and give them the opportunity to work with a real audience or a real set of patients in a real circumstance, so that they can bring value to all the country. And of course, what we do here is we're the thought leaders in many ways for the rest of the world, and this is a biggie. I took this logic and some of the modeling to India in the summer and looked at their national TB, some similar questions that they had in a similar way, and their problem is just staggering. And it was very well received and very useful, but I'll leave that for another talk someday. So,
this is
questions?
Great. This is fantastic, Thad. Thank you so much. I know we are at the end of our time, so unfortunately we're not gonna have time for questions today. I do want to just pause briefly. I know that your mentor Jose is here, and to say, is there any closing comments or observations, Jose, that you might want to make before we close out this session today?
Thank you, Glenna. This is excellent, Thad. I mean, I really enjoyed your presentation, your talk, and I think that if there's a lesson here to be learned is how to be attuned basically to a policy and political reality at every state. I mean, I see it here in New York, and I see that some of the same issues come up in Texas. So, great job.
Well, thank you, and everyone. I am so abashed and sorry that I wasted your valuable time at the beginning of this. I don't have any excuse, but anyway. So
that's
if
quite all right, Thad.
Well, in any case, my email should be available to you guys. If anyone would like to continue this conversation offline or into the future, I'm happy to share it.
That sounds great. And so please, Thad's contact information is on the slides, or you can feel free to reach out to us. We can connect you to him. Also, please join us for our next Research in Progress seminar 2 weeks from today on February 4th. That's a place, and Thad, hopefully you can join us as well. We can continue some of these discussions and think about how they some of the research issues may apply across projects as well. Thank you again, Thad, and thank you, Jose, for the great work on this research. And thank you to everybody for participating today. Please, again, have our next Research in Progress virtual seminar on your calendar 2 weeks from today, next Wednesday.